if for delivering babies early, they might end up with respiratory distress syndrome, and you probably would be aware that for diabetic babies, the lung maturation probably lags behind a little bit compared to non-diabetic babies. And there's a whole bunch of medical complications which may happen after the baby is born, for which they might have to stay in the nursery. So there is an increase in NICU admission. And later in life, these babies are prone to obesity, type 2 diabetes, also some people say low IQ. For the mother, there is an increased risk of blood pressure. The labor, there is increased risk of chance of induction, needing instrumental delivery, or even cesarean section. If they're having a macrosomic baby and instrumental delivery, there's a risk of a perineal trauma like third, fourth degree tears. They usually tend to stay in the hospital longer. They can sort of suffer from some psychological impact from the whole diabetic, like the diagnosis and the management and all that. It takes a toll on them. And long-term risk for them again, the risk of recurrence in future pregnancies. There is an increased risk of type 2 diabetes in later life. So it's kind of a warning sign for these mothers. About 5% will have diabetes within 6 months of birth. About 60% will be diabetic within the next 10 to 20 years. So if they can change some, get some lifestyle changes, exercise, diet, they might end up sort of delaying the diagnosis or not having at all. And there's an increased cardiovascular risk. If you think of developing diabetes, vascular disease, their cardiovascular risk profile will be more worse than the non-diabetic woman. Sorry. So the idea is with appropriate care and support before, after, and during pregnancy, many of these complications can be prevented or the impact would be less. So preconception and assessment and advice. So this actually applies more to people with pre-existing diabetes. People who do not have gestational diabetes don't even know they have, they're going to get it later on. So general advice and education in terms of lifestyle, diet, exercise, all that sort of stuff. Review of medications, what sort of insulin they're on, if it has to be adjusted, if there are some blood pressure medications, are they safe in pregnancy, that kind of thing. Screening for diabetic complications and other medical comorbidities, which would include if they have to need to see an eye doctor or see a kidney doctor because they have a diabetic nephropathy or hypertension. And baseline investigations, including a hemoglobin A1C to see where they are. And then if the hemoglobin A1C is increased, we probably would be sort of talking about tightening the sugar control before they fall pregnant, which I didn't put it up here, was is taking folic acid. So like a good advice for everyone anyway. So when we sort of get the pregnant woman with pre-existing diabetes or GDM, it's a multidisciplinary team. So obstetrician is only one small part of it. There's a midwife. The majority of the diabetes management is done by the endocrine team, which is led by the endocrinologist. There's the diabetic educators who are credentialed with expertise in diabetes management, and dietitians. The general practitioners have the background, so anything else, they actually send the patients in time to the hospital. That's their role. So in Liverpool Hospital, where I work, there's a clinic called COPE Clinic, which is the Combined Obstetric Physician Endocrine Clinic. It's a Tuesday clinic, and I've been in this clinic for the last 20 years. And it's probably one of the busiest clinics because of the number of patients always keep going up. So in first trimester for pre-existing diabetes, they usually start on their care under their GP, and most of them will have an endocrinologist. From time to time, we'll have patients who actually have no care and comes with horrible hemoglobin A1C like everybody else. So the GPs encourage early referral to the COPE clinic, do the booking bloods, and if they haven't had preconception care, they'll revisit the medication, folate, that all sort of stuff. There's dating viability ultrasound early on, aneuploidy screening, including NIPT or an early morphology scan, and type 1, type 2 diabetes, just from the medical perspective, they actually are a candidate for aspirin caltrate. Sometimes some people do not want to take it, and they would rather go a preeclampsia screen, and if they're high risk, then they'll go on to aspirin calcium. And for gestational diabetes, they basically get routine referral to the hospital or a private obstetrician at around 10, 12 weeks. Booking bloods, sometimes they've got sugars done. It's not a routine thing to be doing sugars with all pregnant women. So, but then you find that some of them have high blood sugars in the booking visit, and then they're sort of automatically either gets diabetes or they get sort of appropriate referral and testing. So again, all the same things like the pre-existing diabetic. So screening for GDM for those who are not pre-existing In the past, we used to do a 50-gram glucose challenge test followed by the 75-gram GTT. But then we found that the false negative result was so high, we're missing a lot of diabetic patients. So our Australian Diabetes in Pregnancy Society removed the requirement for the GCT in 2011 and was universally offered to all pregnant women between 24 and 28 weeks. And in the past, there was a 3 days high carbohydrate loading diet required, which is not required anymore. And women with risk factors for GDM are offered an early GTT between 13 and 20 weeks. So the risk factors for GDM, there's quite a lot. So basically, they're more than 40, the non-Caucasian ethnicity, including people from our subcontinent, high BMI, family history of diabetes or GDM in the first degree relative, PCOS, GDM in previous pregnancy, history of macrosomia, that's been debatable, 4 kilo, 4.5 kilo, or in the pregnancy, if they have a fasting BSL greater than 5.1, or they have got excessive weight gain, then they will be like candidates for having the early glucose test between 13 and 20 weeks. So diagnostic criteria, I don't want to sort of make you worry too much about it. Just this is a part which we use now. So after the fasting sugar of 5.1 or more, and then they have a 75-gram glucose drink, and 1 hour and 2 hour, 10 and 8.5 respectively. There's a cutoff used. And these numbers came from the HEPO trial. Second trimester, everybody gets a fetal anomaly ultrasound. It's more relevant for especially the poorly controlled type 1, type 2 diabetes with poor, like high hemoglobin A1C, again, focusing on the CVS and CNS. All type 1, type 2 diabetics are offered a fetal echocardiography at 24 weeks. So that's when we get to see them a lot in our MFM unit. Most of them obviously are normal, but they have got an increased risk of cardiac abnormality, and cardiac abnormality is detected best after 20 to 24 weeks. And then they get regular growth scans. There's no sort of rigid protocol, but I would say around 4 weekly. Obviously, if there's concerns, especially with babies' growth, which is small babies and stuff, if there's anything like associated, they might get even more frequent scans. And there also, later on in the pregnancy, there may be fetal well-being scans, there's Dopplers, biophysicals, and CTGs being done just to sort of make sure baby's well. Timing of delivery, there is no robust evidence to provide direction. So it's based on assessment of multiple factors. So gestational age, in general, I would say most people with gestational diabetes are delivered between 39 and 40 weeks. There is no reason why a GDM diet with well-controlled sugar, normal sized baby couldn't go a little bit past 40 weeks if they really wish to do so. For type 1, type 2 diabetics, the usual gestational age frame is between 30 and 39, earlier if there's other issues. Estimated fetal weight, because macrosomia is an issue. If there is a large baby, especially with a large AC, then that would be a factor. Maternal sugar control, poorly controlled sugar might mean we want to deliver them early. If there's comorbidities, poor outcome, or other standard obstetric indication like PPROM, they will probably get delivered a bit earlier than we come into the decision-making process. Mode of delivery, without suspected macrosomia, everybody should be able to sort of have a trial for a vaginal delivery unless there's other reasons. With suspected macrosomia, the trend is to deliver them between 38 and 39 weeks. The literature usually suggests that if you wait until 39 weeks, you do cut down a lot of RDS cases. But sometimes when they have got poor sugar control and you're worried about the baby and you can't really predict which way things will be going, or women's complaining of decreased fetal movement, there will be a lower threshold to sort of jump and actually deliver these babies. There is a thing about prophylactic seizure if the estimated fetal weight is more than 4.5 kilo. So whenever we have a big baby and we're worried, we usually have to sort of get the patient involved and just let them know there's a lot of error margin with predicted big babies on ultrasound, 15, 20, even more sometimes %. The risk of shoulder dystocia and injury with the brachial plexus, and the risk of third, fourth degree tear, and then the patient can make an informed choice. And other management issues, babies, if they're going to labor, they have to be continuously monitored. There's always an attempt to maintain euglycemia in labor, so the sugar is normal. So to prevent big drop in blood sugar levels for the baby after being born. So like starting them on insulin dextrose infusion if there are a lot of insulin, avoidance of any glucose containing solution, and obviously regular BSL measurements while they're in labor. And scheduling things like, say, elective procedures, we want to schedule them early. So if there's a Caesar list, we want to put the diabetic lady on the first. The postpartum is basically review of the diabetes management for pre-existing diabetics, encourage breastfeeding, talk about contraception, promote healthy lifestyle and healthy weight targets, and regular follow-up with diabetic care providers. And definitely eye follow-up is an important thing, which is always sort of followed up here. Gestational diabetics, they just encourage for same things, but change in lifestyle, hoping they will continue with their dietary changes, exercise, and hopefully delay their development of over diabetes. And this is the last slide. So this is basically diabetes in pregnancy and MFM. So these are the points where we actually get to see the patient, sometimes during the first trimester screening, early morphology or preeclampsia screen. Morphology ultrasound, usually not routine unless there is a reason. Fetal echocardiography, as mentioned before. Growth ultrasound, especially if they're large or small. And fetal well-being assessments later in pregnancy if there are concerns with the baby's well-being. And predicting stillbirth risk from an ultrasound is pretty poor because Dopplers are usually normal, and because the mechanism is fetal acidosis, which is a metabolic thing rather than hypoxia from the placental insufficiency. So it's very hard to sort of pick up which baby is actually going to drop off the perch. Cardiomegaly is something discussed, but it's not really that commonly seen. Thank you.
Thank you, Dr. Shakil, for your excellent presentation. And this is a very informative and academic and also in detail. You have rightly mentioned that many of the complications that occur during pregnancy, like preeclamptic toxicity, that is preeclampsia, premature delivery, macrosomia, and risks of cesarean section, also postpartum persistence of the disease, and as well as development of type 2 diabetes in mother, and also metabolic syndrome in offspring or in children who born to diabetic mother. And the most important thing that I think you have mentioned, that is, if in case of pre-existing diabetes, it is a pre-pregnancy counseling and testing is a cornerstone of the prevention of many complications, especially especially we can know the glycemic status, as well as we can control the disease by starting insulin, also and also hemoglobin A1C less than 6.5%. That is directly related to diabetic embryonopathy, especially during first 10 weeks of pregnancy, if it is very high. And the management, as the one thing I feel that is as the prevalence is increasing, so a good number of women at her reproductive age, they are included in diabetic group, so they are at risk. And the management of the disease, you rightly mentioned that it needs, in fact, monitoring and having glycemic status in a good control. And also at the same time, I also like to mention that the medication, as well as patient's education, self-support, and self-monitoring blood glucose is also important. And we also do, though gestational diabetes is actually varying from country to country, even in the country, due to ethnic group, we know. So however, in our country, we do not go for universal screening, but we do selective screening only for risk group at a booking visit. And another screening is usually we do in between 24 to 28 weeks of pregnancy, and another is at 36 weeks pregnancy. So we can, that is, and in our country, we actually follow the fasting and 2 hours after 75 gram glucose screening test. So meticulous supervision, having diabetes in control, fetal surveillance, and the use of technology, as that is NTA scan at 11 to 13 weeks pregnancy, anomaly scan between 18 to 22 weeks pregnancy, growth scan at 32 weeks pregnancy, can help us to prevent complication, also have good maternal and fetal outcome. And timing of delivery, in fact, in our country, in case of patients who are on insulin, actually we do termination or induction of labor between 37 to 38 weeks of pregnancy, because actually we don't wait more than 38 weeks in many cases because of apprehension of sudden fetal death. And our monitoring level is not such level that we can always ensure the baby is in good condition. However, in that case, we also ask the patient or advise the patient to monitor the kick count, and also if anything found abnormal, we go for doing biophysical profile. And after 32 weeks of pregnancy, though it is ideal to do non-stress test twice weekly, but it is not always possible in our context. So thank you, Dr. Shakil, for
Thank you,
your
Anna.
very brilliant presentation. Thank you.
Thank you.
So if anybody has any question or comment, our next speaker is actually have not been connected yet. So if any question you have, anybody have any question, you can ask Dr. Shakil. I think he is online still. Any question or any comment, please?
Dear audience, if you have any question, you can raise your hand and ask to our presenter.
Connect করা যায় কিনা?
Hi, Dr. Shakil. This is Dr. Bhaskaran from Malaysia. Excellent presentation. Good overview on diabetic management. Just a question. Now, in case if you have a patient who is delivering before 38 weeks, but after 36 weeks, would you offer antenatal steroids in view of the higher risk of RDS? What's your practice there?
Antenatal steroids has been quite a bit of a topic of discussion and debate here, like everywhere else. But if they're sort of, if the general rule of thumb these days is if anybody is having an elective seizure, and that's before 37 weeks, we would definitely sort of consider steroids, diabetic or non-diabetic. For the diabetic ones, if there are a lot of insulin and sugar control is an issue, some of them might even be admitted as an inpatient while the steroids go in to make sure the sugar control is sort of optimal. Whereas if they're actually being induced, say after 36, 37 weeks, we kind of, at these days, we kind of tend not to give steroids for these ones. We'd rather sort of err on the side of having maybe a bit of extended time in the nursery because we've got really good, like special care nursery support. And because of the concern about the late preterm effect of steroids on the baby's brain development.
Yeah, one more question is, your screening, I see that you're using the 3-point screen in terms of 5.1, 10, and 8.5. Do you find that to be picking up a higher rate compared to the 5.1,
it's
7.8?
definitely increased the numbers.
What numbers are you looking at? What percentage in terms of?
I can't tell. I'll make up if I tell you. I don't have that number at the top of my head. But my understanding is like 5 to 10%, somewhere there.
So it's significant. I mean, so you think you should shift to that?
Yeah, it's increase the workload significantly.
Right. Thank you.
Thank you.
Any more question?
Assalamu alaikum. I am Dr. Irene Parveen Alam from Sir Solimullah Medical College. Assalamu alaikum. How are you, Shakil?
Not too bad, thank you.
This is a practical question we are facing in our ward. We have in our unit, I have a patient who have diabetes mellitus and history of previous IUD with polyhydramnios. And in this case, when we should terminate? Now she is 36 weeks and the polyhydramnios, the patient was terminated today because the party was fear of IUD. And practically, when we should terminate this case? Thank you.
Especially if you've got someone with a history of previous stillbirth, and also at present, if there's sugar polyhydramnios, I'm assuming the sugar control is not that great. So having an induction around 36 weeks doesn't sound like it's like good lab management. I'm sure we do a lot of those too. So it's very hard to sort of give a black and white cutoff where should be 35, 36, 37. It's basically you have to individualize with the patient, with the history, with the sugars. And if there's concerns and you're worried about the fetal well-being, and especially in the context of Bangladesh, I understand that if you miss the boat and you might really sort of have a very bad outcome for the patient. I think 36 weeks, 37 weeks sounds perfectly fine. We usually try to aim around 37, but if, as I said, if you got polyhydramnios, poor sugar control, we have done even 35, 36. And if needed, we talk to the pediatricians, the neonatologists, and if they want for the baby, they're worried about it, we have given babies like these, like mothers, steroids before delivering them, even say 34, 35 weeks.
Due
Dr.
to some
Shakil, in one study in Bangabandhu Medical University,
Yes.
it has been found that there is a postpartum persistence of GDM, persistence of glucose intolerance, is that is more than 40%, according to ADA criteria. So, what is your experience, in fact?
I don't
in
think the
Australia?
percentage is that high here. I think we're kind of sort of talking about sort of 5% or less people who would continue to have diabetes, like impaired glucose tolerance after the pregnancy over. Most people, the sugar becomes normal if it's gestational diabetes. I think for you guys, because you don't do universal screening, so the ones which you diagnose as GDM, probably a good percentage of them might be actually already like undiagnosed, just like type 2 diabetes. So that's why the sugar probably doesn't come down. So it's a bit hard to sort of explain, but I think that probably is one of the reasons you will have higher numbers of women with impaired glucose tolerance afterwards compared to us, because we do universal screening, so bigger population, so most of them get better. But if you sort of do selective screening for high-risk population, so you probably will have lots of undiagnosed type 2 diabetes in that group. And yeah, that's what I think.
Thank you for your input.
Assalamu alaikum. Dr. Shakil, how are you?
And one
Not too
thing,
bad.
in fact, the GDM or diabetes, pre-existing diabetes, whatever it may be, the prevalence is due to increasing prevalence is due to lifestyle modification as well as dietary habit change and stress of life as well as aging, we know. And our society, including parent society, many societies are actually, in fact, we are organizing many sessions through talk show, discussion, and we are, in fact, trying to aware the patient. And so, is that this is the one sort of way that we are informing, that we are giving the information about diabetes, about obesity, about healthy diet, about maintaining healthy weight also. And also we have a school program also, and many times you connected virtually with school students, with many schools, and trying to avoid the adolescents also to avoid obesity. Is there any other way or any suggestion
I think
that can
as
help
a
us?
Bangladeshi myself, our diet is pretty bad. We eat a lot of rice, a lot of carbohydrates, and that's like our staple thing. We can't think of having a day without having at least once or twice rice. When you see these people here, they hardly ever have like carbohydrate like us. We usually have like thala bhora bhat na hole amader hoy na erokom type. So that doesn't help the patient. So it probably, if we can sort of introduce in our society in general more sort of healthier sort of diet with sort of low GI food and more vegetables and stuff like that, maybe it will sort of in longer term improve the health of the general people and reduce the numbers.
Thank you, Shakil.
No worries.
I have
We
one
got
question. Madam,
Dr.
I have one
Sadhana
question.
is, I think, connected with us. So I am.
Salam apa?
Hello.
Salam bodu na
Hello,
pa,
Sonic.
Thank you,
Yeah.
thank you,
How are you?
Shakil, for your
Remember
excellent
me.
presentation.
I read your, sorry.
Having with us and giving us such a brilliant presentation. So now I am handovering the mic to one of our co-chairperson, Professor
Madam, I have one question.
Begum Nasrin.
Can I
What is
proceed?
your question?
Yeah,
Ask,
thank
please
you.
ask. Dr.
Okay.
Dr. Shakil, are you here?
Yes, I'm here.
Yeah, Dr. Shakil. Actually, I am very much pleased to seeing on you in this session. So actually, I have, you know, the diabetes is now endemic problem. Now in rural area, it is more and more of bad obstetricity. I'm facing now at this moment two problems. One patient is, you know, that 32 is previous 1CS, and she is in 32 is fetal uncontrolled diabetes. Within 32, she's baby is 3.6 kg. Patient is not so much attentive, and that is totally uncontrolled. Now problem is the patient does not want to stay in the hospital. She wants to go home with some medication. And actually, how can I monitor the patient, baby, and how can I manage the patient, and at what time I will deliver the case?
It's very hard. It's more of a systems issue rather than a medical issue, because patient doesn't want to stay in the hospital. So I think you probably have to be very frank with the patient and just sit down and talk to her, see whether you can put some sense into her head that what she is doing, she's basically risking the baby. If you can put some fear of, you know, a bad obstetric outcome, she might be sort of changing her mind. Otherwise, I hope you guys, manage the diabetes in conjunction with the endocrine doctor, because here we have got nothing to do with the insulin or tablets. Everything is done through the endocrine team looks after it. So I really don't know how to sort of manage lots of bad blood sugar. We usually just bring them in if that's the case. And in terms of monitoring, I don't know in your setting how much you can do in terms of ultrasound or CTGs and stuff like that, though these haven't really showed to help. Sugar control is the mainstay. And I would say, depending upon when is the earliest you can safely deliver. So if it's some 34 weeks, 36 weeks, you have to choose depending upon your circumstances. Otherwise, if you're really, really worried and the patient is still sort of early for your place, you might have to sort of refer her somewhere where they can deliver her a bit earlier than what you can.
Thank you. Thank you, Dr. Shakil Ahmed, for your very interactive discussion. I am Dr. Begum Nasrin. Welcome to Dr. Sadhana Gupta. She is the next speaker. She is the co-chair of Suffolk NCD committee, past vice president of FOXY, and senior obstetrician, J&J Hospital, Gorakhpur, India. Please welcome Dr. Sadhana Gupta. Ma'am, are you present?
Yes, I am present, and I really wish to know that my presentation is there or not, because I have sent video to presentation to Dr. Tabassum. I'm here to actually take the question answer session because I'm not in the country, so I'm not in the my place. Dr. Tabassum, have you my video?
Her topic is gestational diabetes in South Asia, challenges and solution.
Can I go for, I think, Dr. Shakil has...
Okay, madam.
Hello?
Is there any question from audience?
So I will just like to say, because my presentation is not there downloaded and I am not able to have my presentation on the screen. One word about what Dr. previous speaker has taken everything. I will say one or two things to my presentation. By the time I think Dr. Tabassum is able to download my presentation about use of oral hypoglycemic agent. So I will just like to say few things about oral hypoglycemic agent, that oral hypoglycemic agent are always the second choice into the management of GDM, and as a developing countries we are sometimes think that we can write left and right about oral hypoglycemic agent. So oral hypoglycemic agent is always a second line choice. Metformin is the preferred drug over glyburide, but there are two issues with the oral hypoglycemic agent. One is the metformin. I will take that the metformin has 700 times concentration in the fetal blood, and that's why we are not sure that what is their long-term effect. And the TOFU study says that the visceral fat is much more in the long-term effect at the age of 8 years who have been given metformin. And the second thing is when there is a hypertension, preeclampsia, IUGR, or the previous history of stillbirth, then the metformin is not the drug to be taken as a choice, and the insulin should be always preferred over the metformin and oral hypoglycemic agent. So metformin has got a good blood sugar profile. It has a good effect on the neonatal birth weight, less incidence of neonatal hypoglycemia, but there is a issue of two things, that in 46% of cases there is no optimum blood sugar control, and we don't know what will be the long-term side effect. So be careful with the use of metformin. Doses is usually we start at 500 milligram at night, and then 500 milligram BD, and then TDS if it is required. But mind it that 46% of the patient they are not able to have a good blood sugar control, and insulin might be added therapy. Glyburide is considered lesser choice because it is having more gestational weight gain and more fetal macrosomia and more fetal neonatal hypoglycemia. So glyburide is inferior to metformin as well as the insulin. So I will keep it to a few ground root challenges because presentation is some issue with it. So the one clear message, then the insulin. So in low resource countries, like we think that it is very difficult to give the insulin therapy. So my experience, I am dealing with a lot of rural population and all over the country, that if we have a good diabetic nurse educator and the trainer, we can teach everybody to give the insulin, how to self-administer insulin, as well as monitor the blood sugar level as well. So it is our duty. One very important message which I want to give to all audience, that self-glucose monitoring is doable thing. It is cheap, it is cost effective. And when we have got this diary of the blood sugar level, if we can teach the patient, we can teach the family, then it really makes diabetic management optimum, because we know what is the blood sugar level. It is normal, it is beyond, how many readings are beyond blood sugar, what is desirable level. So 2 or 3, because the previous speaker has taken, so I'm taking 2 or 3 good clinical messages, that metformin is the second drug of choice, insulin is a gold standard, and we have to train and we have to believe in our people that the insulin and the glucose self-administration insulin and the self-glucose monitoring is doable thing. So third issue, that is the ground challenges in the South Asia, that the multidisciplinarity. So do we have the physician? Do we have the dietitian? Do we have the endocrinologist in our team? And most of the time, as an obstetrician, we must have the basic knowledge of all the issues like insulin, what is the dosage required. It is usually the self-administered glucose. It is once or twice, 30 by 70. And then when whenever we can have the take multidisciplinary unit. The third issue is about that challenge in the South Asia is the maternal nutrition therapy. So how much our doctors know about the maternal nutrition therapy? As our previous speaker, Dr. Shakil, was saying that we have a very high carbohydrate diet, and actually being in South Asia, we are fortunate to have a variety of fruits, nuts, vegetables in a quite a low cost as compared to Western world. So issue is about the education, and doctors ourselves should be aware that what is the quality of diet, what is the low glycemic index food, what are the high glycemic index food and the low glycemic stand, and always we must be able to tell that what is culturally available, economically feasible. Like if we follow any Western world recommendation or something.
Hello.
So it goes, yes, am I audible?
Thank you, madam. Now we'll hear from the recorded presentation of Sadhana ma'am. So please start the recorded presentation.
Thank you.
Good afternoon, everyone. Greetings to Bangladesh from India. We are going to discuss what are challenges and solutions in management of GDM in South Asia. It is about me, and I owe a big gratitude to all SAFOG leaders for being together since a long time as my tenure for FOXY representative to SAFOG and now as a SAFOG co-chair NCD committee. So we say that South Asia loves festivities and celebrations. Are we prone to diabetic as a race? Or it is a result of sharp change in lifestyle and environment which has created epigenetic change. It is a question before us, but it is a fact that GDM is around the corner and can be anywhere in obstetrical population. GDM is an important public health issue in India as well as South Asia because it represents large subset of population at high risk who can have adverse obstetrical outcome and even mortality if it is not appropriately managed. Besides this, the perinatal implication of GDM marks beginning of a vicious cycle because diabetic mother gets diabetes, leaving a legacy which can affect to mother as well as her offspring. Her mother can have the frank diabetes mellitus later on, and her offspring can also have metabolic disorder. So at the moment when South Asia is facing tsunami of non-communicable disease, our intervention from obstetrician, a good screening, a good care in the management of GDM can go a long way in preventing this tsunami of non-communicable disease in our population. So what is GDM? It is a carbohydrate intolerance of variable severity, which is either developed or it has been discovered for the first time during pregnancy, irrespective of gestational age at which it is diagnosed. It is definition still implies whether we use any pharmacotherapy or not, and it also includes some women who have previously unrecognized over diabetes. Why we use GDM? Because the term gestational has been encouraged to communicate the need for enhanced surveillance and to stimulate women to seek further testing postpartum. So GDM, we have to be very clear in defining. As I say that it is the intersection of two important area of health, that is maternal and child health and non-communicable disease. And both are a crucial health issue in South Asia. And the potential for successful management will determine what is the pregnancy outcome, and it also have the opportunity to prevent type 2 diabetes mellitus in later life. And here we join hand among all countries of South Asia that how we can do the best for our women. It is the most common metabolic disorder during pregnancy. In Asia, the average can be from 5 to 16%. And out of these, 7 to 8% of GDM patients are insulin dependent. And International Diabetes Federation estimates that around 2015, around 16.2% of women with live birth had some form of hyperglycemia in pregnancy. So magnitude is a big, and with a large population what South Asian country have, we contribute to a good number of absolute patients who are having GDM. So it is again emphasized the Shashya, who has been known as a father of Dipsy set and father of creating awareness about GDM in India. And he also concludes that right from rural to urban, the incidence of GDM range from 9.9 to 17.8%. In Sri Lanka and Nepal, the prevalence is a little low, that is around 5.5 to 7.1. So it can be right from 5% to 16% in incidence of GDM in our obstetrical population. Now, screening for the GDM is the question is very, very simple. And we come to, first we ask the question, it should be universal versus selected. At what trimester we should do screening first and late second, or we have to confirm in third trimester also. And how do we screen for the GDM in a large number of normal obstetrical population? So the many professional bodies have got a different recommendation, and in India we are in line that we follow mostly the DIPSY, because as we say in the Western world the incidence of GDM is low because of many factors, because of ethnical susceptibility, and it is our problem which we have to face the challenge. I want to convey very, very important message that urine glucose testing, fasting plasma glucose or random plasma glucose or the postprandial plasma glucose have the low sensitivity as a screening test for GDM. So it should not be used as a screening test for GDM. Because if we do testing without administering a glucose load, which will help to come the impaired, a minimal degree of carbohydrate intolerance to become over. And a HAPO landmark multinational study demonstrated that we have, when the mother who have the higher glucose level, they have the more adverse obstetrical outcome. And the previously considered normal values are associated with the adverse perinatal outcomes. So we have lowered the bar of glucose level in pregnancy, and that is less than 100 milligram per deciliter as a fasting blood sugar. Our Indian guidelines and the FOXI recommend the screening for GDM at first visit, and then it has to be repeated again in the second trimester. And in Sri Lanka, there is a universal screening of GDM at 24 to 28 week pregnancy, beside the screen for pre-gestational diabetes at the booking visit. So yes, we have lowered the bar for the diagnosis of GDM, and that has also contributed to increase in number who has been diagnosed at GDM, but the lower glucose level are related to a good obstetrical outcome, and this is the way forward. So the DIPSY recommendation, that is Diabetes in Pregnancy Society of India, that the universal screening is recommended, and it should be first at the 16 to 18 week, then 24 to 28 week, and a woman, irrespective of her last meal, is given 75 gram anhydrous oral glucose load, and after 2 hours a venous sample is taken and the plasma glucose level is estimated. And if these value is more than 200, the patient is considered frank diabetic, and if it is more than 120, then it is says impaired glucose tolerance, and if it is more than 140, then we label that this patient is having gestational diabetes mellitus. So second question to our clinician is that yes, we do universal screening, though it is still important to take the history indicated risk women and do the closer surveillance for the GDM. Yes, answer is yes. Women who are at high risk of over diabetes like glycemia is a very common side effect. However, glyburide is not considered a very good drug for the management of GDM. This I want to emphasize to all audience, because it is associated with higher incidence of macrosomia, neonatal hypoglycemia, preterm birth, and again in around 20% of women, there is no real control, a good control of blood sugar level. So glyburide is not that it has got associated with less control of blood sugar level and the more neonatal complication like large for gestational age, RDS and NICU admission. So as a monotherapy, glyburide is inferior to both insulin and metformin. And metformin with or without insulin can be considered in select situation. And we still don't have the safety data for the long-term effect of metformin, and that should be communicated to our patient. So finally, a word that what is the place and role of oral hypoglycemic agent in GDM? DIPSI still doesn't recommend oral hypoglycemic agent for the first-line management, and the final takeaway we can say that the oral hypoglycemic agent, that is metformin. I will say glyburide is not drug of choice. Metformin can be considered as alternative to insulin when the patient need pharmacotherapy. Like 30% of blood sugar level are higher on maternal nutrition therapy, but they decline to take insulin or they are unable to comply with the insulin therapy. Various guidelines are inconsistent, and the second choice is when the patient is having normal fasting blood glucose level and the modest postprandial hyperglycemia. So patient is having normal fasting but a little higher rise of postprandial hyperglycemia, then metformin can be considered in those select situations. Besides this, that the couple or the family is not at all able to maintain the insulin regime. So this is very clear message, and we should be very, very clear that which patient need can be selected for the oral hypoglycemic agent. Inositol has come in a big way because the medicine is searching for the nutritional supplement, not the drug for the many disease. And the many research says that if we give inositol supplementation, it prevents the development of GDM, or it prevents the severity of it reduces the severity of GDM. So still we don't have the final evidence, but it is a good thing because these are inositol, they are nutritional products, and they don't have any side effect. So coming to insulin. So after understanding that how the two drug act, metformin is better drug, but it is always a second line drug, and the patient has to be selected. A very, very few number of selected patients can be considered for the oral hypoglycemic agent. Now, when to start insulin? Again, whenever the maternal nutrition therapy is not able to maintain the good blood sugar level, and we have to switch. Insulin is still the gold standard therapy. Now, we can say that we can refer to the physician or we can refer to endocrinologist, but majority of our patients as well as us are not that always availability of this, that you ask the patient to say, ask physician to go physician to today and they will go after 7 days. So we must have the basic knowledge what is insulin and how the dosage is adjusted. If the patient is having pre-existing gestational diabetes mellitus, it is 0.7, 0.8, 0.91 from the first trimester to the term, and these patients need 3 injections or maybe 4 or 5 injections. But if the patient is only GDM, you have detected in second trimester, then usually the once daily insulin may be suffice, or sometime twice a day if the fasting blood sugar level is high, and the pre-mixed insulin is most convenient. So we must have as an obstetrician the basic knowledge, that is 30-70 insulin, which is given just before the breakfast and before dinner. And the single injection sometimes it is only needed with the GDM who are having.
Hello, madam. We are already short of time. Thank you for your very nice presentation. You have highlighted both the screening of gestational diabetes and regarding the management. Thank you, madam, for your brilliant presentation. We learn lot from your lecture. Thank you. Regarding diabetes, we all know that diabetes is the most common complication during pregnancy. In South Asia region, more than 10% pregnant women suffer from diabetes and gestational diabetes mellitus, though 90% are gestational diabetes mellitus. Pre-gestational diabetes and diabetes both associated with very many maternal and perinatal complications. So, screening of gestational diabetes mellitus is mandatory to prevent its complication. As the incidence in the Southeast Asia is high, so universal in our perspective, universal screening at booking is recommended. In our country, we do OGTT or modified OGTT one step methods. In India, DIPSI is popular, but in our setting, we are not doing DIPSI. Regarding management, most of the patients respond to medical nutrition therapy and 10% patient need insulin. Maintenance of the euthyroid status throughout the pregnancy is mandatory. Routine fetal surveillance by ultrasound, kick chart, NST and biophysical profile is done. Time of delivery, decision regarding time of delivery is very important. As we know, if we do prematurely, the baby may develop respiratory distress syndrome, or we may do late, then in case, many cases there is unexplained IUD. So decision regarding time of delivery should be balanced and thoughtful. And next, regarding postpartum follow-up. Postpartum follow-up is very important for all the patients. I know that in case of GDM, most of the patients come to euthyroid status after delivery of the placenta, but in some patients, diabetes persists. So at 6 to 12 weeks, OGTT should be done. And if negative, these patients should be followed up throughout life. Every 1 to 3 years, OGTT should be done to see whether these patients are developing type 2 diabetes. So thank you, audience. Thank you. I am very much honored to chair the very important session like diabetes in pregnancy. Thank you all.
Thank you. Thank you.
Thank you, madam. We are at the end of the session. I think all of us have learned many things from this session. Now, I am really very grateful to utter the name of my mentor, the guide, the pioneer of maternal fetal medicine, Professor Firoja Begum madam, who has recently written a book, High Risk Pregnancy. I would like to call upon our first chairperson to hand over the book to our second chairperson. And vice versa, that means. Now requesting my second chairperson to our first chairperson. Thanks to all, and I'd like to request our next rapporteur to conduct the session.
Bismillahirrahmanirrahim. My respected teachers, honorable guests, ladies, gentlemen, and participants from home and abroad, Assalamu alaikum and good evening to you all. Me, Dr. Runa Akhtar Dola, welcoming you all in the last session of Second International Conference of Maternal and Fetal Medicine Society of Bangladesh. Our session is on the topic obesity and pregnancy. Obesity is a global health issue nowadays, and pregnant women who are obese have much more pregnancy-related complications, and management is also very tough. We are delighted to announce that we have one speaker today. He is Professor Pankaj Desai sir from India. He is going to talk on the topic today. It's my pleasure to introduce my chairpersons of this session. They are Professor Najma Haq Madam. Professor Najma Haq Madam is working as a professor and head of the Department of Obstetrics and Gynecology of Dhaka Medical College, the biggest medical college of Bangladesh. She is also working as a unit head of oncology in DMCH, and she is working as a treasurer of Gynecological Oncology Society of Bangladesh and master trainer of colposcopy and PPH. Our next chairperson is Major General Professor Lija Chaudhary Madam, Professor and Head of the Department of Obstetrics and Gynecology, CMH Dhaka. She is the Head of Fertility Center of CMH Dhaka, and she had her fellowship in Infertility and Reproductive Medicine from India and diploma in ART and Reproductive Medicine. She has 20 national and international publications and attended more than 100 conferences in home and abroad. It's my pleasure to call upon the dais to my chairpersons. Dear audience, you have already known that we have one speaker today. He will get 20 minutes for the presentation. The speaker is requested to complete his presentation within time. And if you do have any question, you can ask it at the end of the session if time permits. Now, I handed over the session to our respected chairpersons.
Assalamu alaikum and very good evening to all the dignitary audience. For giving me this opportunity to address an international obstetrician in this session, I would like to thank to the organizer of the Maternal Fetal Medicine of Society of Bangladesh. I would like to request Professor Pankaj Desai to present his excellent deliberation. Professor Pankaj Desai actually is the obstetrician and the consultant of Janani Maternity Hospital of Baroda, Gujarat. And he was the former Dean, Student Associate Professor and Unit Head of Medical College of Baroda. He is a gold medalist awarded in OBGYN. He has publication more than 100 and he has a research paper awarded Best Paper Prizes, which is number 9. And she is the author of 13 books. He has contribution of the chapter to different textbook also, which is number more than 44. Now I am requesting Professor Pankaj Desai, please deliberate your presentation on a special metabolic disorder in pregnancy, which is the obesity in pregnancy, the upcoming challenges. Please, Professor Pankaj Desai.
Thank you very much. Can you hear me?
Yeah.
Okay. Can you see my screen?
Yes.
Okay. Honorable Dr. Nazma Haq, Honorable Dr. Major General Lisa, thank you for chairing my session. Also thankful to Dr. Firoza Begum and Dr. Tabassum for meticulously following up and organizing such a wonderful conference. I am aware of the fact that this is the last session, academic session, I am the last speaker. And usually there are very big stories of the last speaker. Once I saw that there are only 4 people in the hall, and I asked them, 2 of them said that they are chairman of the conference, of the session. And the other 2 I asked, why you people are here? They said that, sir, we are audiovisual people, we want you to finish and we want to pack up. So I understand that you must be all feeling very relieved and want to go home. So let me go cracking as usual with a prayer. Oh Almighty, may He protect all of us. May we acquire strength together. May our knowledge become brilliant. May we not hate each other. Oh Almighty, may there be peace, peace, peace everywhere. The recording of this lecture is already available on my YouTube channel. The text is available on my website in my recent lecture section. And the crux of this lecture is available on my blogs, Dr. Pankaj Desai's blog. You search and you'll get it. Friends, the problem which we are going to discuss in the next 19 minutes is actually a new entrant in OBGYN horizon. We were in a comfort zone of routine obstetrics, and suddenly this has come and fallen upon us, and that is Therefore, we are finding it a little difficult, and we find some dilemmas because the data is still not complete with us, and therefore we try to find out new things and certain uncertain things before us. And the topic, therefore, is obesity in pregnancy. You need not go very far for this. See this picture. They are not some big celebrities. It is a typical picture of before 1971. All these changes have taken place in and after 1971. Till then, obesity was not a big problem, and now it has become a global pandemic. This is very interesting. And why so? Only one clearly identified causations, though many associations, and that is increased consumption of sugar and sugary products. The numbers are scary. The probability of conception declines linearly starting from a BMI. Suppose you take a BMI of 29 kilogram per square meter, it reduces by 4% with every additional 1 kilogram per square meter. There is a 10% increase of pre-gravid BMI, and that increases the relative risk of gestational diabetes and preeclampsia by around 10% each. And a 5 kilogram square meters of increase in BMI elevates the relative risk of intrauterine death by around 0.24, an absolute number. Now let us quickly see the maternal risks. Maternal risk associated, the risk of miscarriage 3 times increases, not by 3%, but 3 times. Operative delivery 1.5 times. And the odds of developing gestational diabetes 3 times higher. I will not go into diabetes any further. We had exhaustive session preceding this. And it does not stop at this. There are many other risks. And what are they? Increased risk of preeclampsia, the topic of my study all throughout life, by 4 times. And this is attributable to increased demand of the baby, which are large for gestational days, gestational date, and there is a compromised cardiovascular function. In itself is a separate lecture. Then the patients were divided. 2022, a very recent article. I have tried to bring in recent research, and they were divided into 2 groups, and it was found that if the pre-pregnancy BMI, I'm not telling BMI now in pregnancy, but if a pre-pregnancy BMI was more than or equal to 25, there was an increased risk of post-date pregnancy. So even post-date is a bit small. Respiratory problems. Obstructive sleep apnea causing fatigue, increased risk of hypertension and heart lung problems are rampant with obese. And obesity is not a remote problem. I am getting pregnancies starting at 128 kilograms. My last pregnancy around 5 months before of an obese patient started at 128 kilograms. You can imagine where it must have reached. And this is having a weight of 99 and 100 is now becoming a routine sort of thing. And when the pregnancy ends, you can imagine where it leads up to. So therefore, it is not something very remote or distant. There are also a high risk of non-pregnancy pulmonary complications such as cesarean section. And cardiovascular also are interesting. It is not only a heart failure. Pre-pregnancy obesity is associated with an increased risk of peripartum cardiomyopathy, a potential killer, and a 50% of maternal deaths from VTE today in the UK are obese. And that thromboembolism, a very quick word on prophylaxis. This can help. And early ambulation is the key. Maximum data from this part of the world is for early ambulation. However, low molecular weight heparin now routinely is being started. The standard treatment, if you can jot down, is 0.75 to 1 milligram per kilogram for every 12 hours based on actual body weight till the patient is completely ambulatory or up to 3 months postpartum. Please note this down because I know some people are going to email me regarding this dosage. And the first dose is to be given as soon as possible after delivery, provided there is no PPH and regional analgesia has not been used. So quick use of low molecular weight heparin. Fetal effects, perinatal mortality 4 times more, and the incidence of macrosomia is double. Estimated 11% of neonatal deaths can be attributed to maternal overweight and obesity. All latest data. During pregnancy, overweight women are at increased risk of congenital birth defects such as neural tube defects, heart defects, and gastrointestinal malformation. Something surprising for me, probably for you also. The misuse, and this is 2021 article, the misuse of antibiotics during pregnancy is positively correlated with the risk of obesity in 5-year-old children. So be careful the next time you prescribe an antibiotic. Is it really of use or a misuse? Because the effect lasts for years together. The pathophysiology. And the pathophysiology, we will have to go deep into it. I'm going to suck you inside only 2 slides, however. Normal pregnancy, we all know, is associated with increased insulin resistance, and this is amplified in obese mothers. Insulin resistance is normally compensated by mother's body by increasing her pancreatic beta cell mass together with enhanced insulin release. So one side, just because she is pregnant, she is having insulin resistance increased, the mother compensates it by increasing her insulin release. However, in obesity, there is a pro-inflammatory environment, and that disrupts this response of the beta cells, resulting in an increased risk of gestational diabetes and allied complications. This is a very important pathophysiology. Epigenetics has come to catch our eyes. Most of you know, I know this audience, most of you know what is epigenetics. A quick revision. Epigenetics is the study of how your behaviors and environment can cause changes that affect the way your genes work. Unlike genetic changes, epigenetic changes are reversible. Please understand this. They do not change your DNA sequence, but they can change how your body reads a DNA sequence. So till here, you have something in control, and therefore take advantage of it. A mounting body of evidence implicates epigenetic mechanism in the regulation of these effects and the transmission to future generations. And I will give you one very solid evidence. We all know that in Asia and even in nearly the world, the longest surviving people are the Japanese people. And you are seeing on the left side of yours that this is how normally the Japanese are, lean and thin people. However, those Japanese, young Japanese who have migrated more and more to the urban areas have changed their eating habits. And now obesity has become a big problem in adolescents and young adults of Japan, and the mortality is going down as regard the age is concerned, and earlier mortality is occurring. And this is completely attributed to the epigenetics of it. And that epigenetics is the faulty way or the unhealthy eating habits. One new insight which has come now, which you and me as obstetricians can intervene. Intrauterine exposure to obesity is associated with increased risk of developing obesity and metabolic disorders. So today, if I have obesity and a metabolic disorder, there is something related to my mother in her pregnancy. She passed away 26 years before. And I have no hesitation in telling I am a child of a mother who had polycystic ovarian syndrome. So I have a susceptibility to this condition. Even after decades together, in 50% of large for gestational age offsprings of mothers with gestational diabetes, and in 29% of LGA offsprings of non-diabetic mother, metabolic syndrome can occur up to 11 years. Up to 11 years after birth. And that brought in the Dohad theory, the developmental origins of health and disease. And there is a role for early life environmental exposures, which is critical in determining long-term health of individual. So not only we all have a duty towards the current pregnancy, but for years together, our effects, if we are not alert, which we will now be, then this can happen. Adverse nutrition in early life, increased susceptibility to metabolic syndrome is the Barker's hypothesis, which we all know what all it includes. Now see this graph, this diagram. It will make things very clear. Pre-pregnancy obesity is there, pre-pregnancy. That is where you can intervene. Produces diabetes in pregnancy, larger and fatter babies, childhood obesity and insulin resistance, adult obesity and insulin resistance. Now, if you bring in pre-pregnancy weight loss, don't allow her to get pregnant or request her, if possible, to postpone pregnancy till she has lost her weight. Then obesity goes down, pre-pregnancy, diabetes goes down, larger and fatter babies go down, childhood obesity in the newborn child and subsequently goes down, which has its effects even in adult obesity, and insulin resistance goes down. And as a female, if she gets pregnant, she doesn't have a pre-pregnancy obesity, a decisive cutting down of this vicious cycle. So as obstetricians, our effect can be very long lasting. And this is a vision which is based on science, which is now picking up very fast. Pregnancy is looked at as a window of opportunity to improve long-term maternal and infant health, and pre-conception care is the way forward. At antenatal care in obesity, we might be very late. Pre-pregnancy weight loss between pregnancies, that is pre-pregnancy weight loss, reduces risk of stillbirth. This is data. Hypertensive complication, fetal macrosomia, and weight loss increases the chance of a successful vaginal birth after cesarean section. Now she has come to you in pregnancy. And many of you are asking this question. Can she do exercises? Yes, she can. 2021 January, latest data, exercises were a very big no. We were afraid of it. A recent meta-analysis included over 2,000 women showed that aerobic exercises and moderate intensity, even toning exercises. Please don't be afraid. I know obstetricians who tell, go for a walk, that is enough for you. No, for obese women, even aerobic exercises and moderate intensity toning exercises performed 3 or 4 days per week throughout pregnancy was not associated with any increased risk. Please take this message loud and clear. I know this is the last session. Many of you would like to go home, would like to go to drift to sleep, but then I'm banging your heads a little. Exercise is safe in these women and should be encouraged. Even the previously sedentary patient who have never exercised can start exercises in pregnancy, and it is safe even in some of the high-risk pregnancies such as chronic hypertension and gestational diabetes. So don't be afraid, please. Last part, and that is labor. Elective induction in case of morbid obesity at 39 weeks may entail less risk. 39 weeks is the cutout, not 40. Labor progression from 4 to 10 centimeter expected to be slower, and I tell you the reason soon. And data suggests that obesity is associated with inefficient uterine activity in labor. And you would like to know why. What has obesity got to do? I will tell you. The leading cause of this is higher frequency of cesarean sections because of the inadequate uterine activity. And that is because there is an altered biometrial function in obese women regarding their uterus is concerned. And who is the villain? The myometrium of obese women exhibited a lower expression of connexin 43, a lower function of oxytocin receptor. So the oxytocin receptor is inefficient, and therefore higher activity of potassium channels. Anesthesia complication itself is a huge lecture, and I will not go into it. BMI more than 40 kilogram per square centimeter is pressure sores and mental health problems. Now, what about bypass surgeries? Pediatric surgeries are safe. Perinatal complications were less. However, 2018 and ACOG both say so, but minimum waiting period is 12 to 18 months. What about anti-obesity or weight loss drugs? Not recommended for use in pregnancy. Metformin for overweight patients without diabetic mellitus does not improve pregnancy outcome. So friends, in the remaining 50 seconds, we have to be, I am on 19 minutes and 15 seconds. Obesity is here to stay. Malnourishment, low nourishment, hyponourishment will go away. World is progressing, but obesity is here to stay. And therefore, these are the obstetricians. And this is the challenge we have to face. Don't be afraid. With science at your side, we will be able to dance with this problem. Thank you, ladies and gentlemen. Thank you very much.
Assalamu alaikum. Very good evening. I would like to congratulate Professor Pankaj Desai for his outstanding presentation. Worldwide, the obstetricians encountered with increased incidence of obesity among pregnant women. Obesity is associated with almost all complications like gestational hypertension, preeclampsia, eclampsia, gestational diabetes, delivery of the large infant, incidence of congenital birth defect, thromboembolism, and metabolic syndromes, and so on. Evidence show that child of a obese mother suffers from exposure to suboptimal environment in utero. So, early life adversities may extend into the adulthood. Professor Pankaj Desai beautifully explained the phenomenon of developmental origin of adult disease, it very elaborately. And he explains the epigenetic changes, Barker hypothesis, and the changes which delays the labor and all at all outcome of pregnancy and labor. Thank you very much for fantastic presentation. And it is a very extraordinary and very nice presentation at the end of our conference. Increase our knowledge and increase the, we can manage the cases nicely. I want to request our co-chairperson to say something.
Thank you. I would like to thank, a lot of thanks, Professor Pankaj Desai, for your time-demanding deliberation. Really, I always say that time-demanding as an obese woman, because who are obese, they don't feel it's a problem. They increase their weight day by day, but we, the obstetrician, we feel what's a horrible condition she or her intrauterine fetus may develop. So it's a very time-demanding topic. You so intellectual presentation, and it is be helpful for all obstetricians because they can meticulously deal an obese woman in pregnancy. Thanks a lot, Professor Pankaj Desai. Thank you.
Learned audience, we are at the end of the session. Now I humbly request our chairperson, Professor Najma Haq Madam, to hand it over the book written by our mentor, our mother figure, our pride, Professor Firoza Begum Madam, to our another chairperson, Brigadier General Professor Liza Chaudhary Madam. I request Firoza Begum Madam to come upon the dais and give the book of appreciation to our chairpersons. It's my pleasure to thank our chairpersons to conduct the session so successfully. I also thank to our speaker, Professor Pongos Desai sir, for her wonderful presentation. And also thank to the participants for your patience hearing. And last of all, I want to thank our pharmaceutical companies for their excellent support in all aspects to make this program successful. Thank you all.